έτοιμοι να ξεκινήσουμε με αυτή τη μικρή αλλαγή στο πρόγραμμα που σας ανέφερα και πριν από λίγα λεπτά. So it's an honor and a pleasure to have with us Professor Enrico Clini, who will give his talk on the opportunities and challenges of treating acute hypoxemic respiratory failure. Professor Clini, the stage
Thank you very much. Thank you very much for the invitation, the society, the president, and all the Greek friends I had the opportunity to meet today. And also thank you for having anticipated my talk, because I have to go to the airport to take my flight back. The title is Treating Acute Hypoxemic Respiratory Failure. I will try to give you some news, advice, or some curiosity about how treating from a pulmonologist's point of view this syndrome. This is my disclosure, which partially have to do with some of the data that I will present to you today. The first slide is just to introduce you the context at which we refers with this topic. We are talking about respiratory failure, and in particular hypoxemic respiratory failure, which is a very important and life-threatening condition for the patient due to inflammation, edema of the lung, which regards, when we talk about a subtype, which is the ARDS, as you know, at least one every 10 patients admitted to the ICU. Although the ARDS in particular have a very complex pathophysiology, and we have no time to discuss about that, which is not fully understand. Basically, it refers to alveolar damage and inflammation in the lung, but not the inflammatory pattern of ARDS and following respiratory failure and hypoxia depends on inflammation. Indeed, today we know that intensivists in particular have clearly defined that we have subtypes of ARDS, likewise inflammatory ARDS or non-inflammatory ARDS. But my talk will be according to this agenda, so I will try to look or briefly define which is the role of non-invasive respiratory support to treat hypoxemia, and then in particular to focus on respiratory effort, which is one of the causes for delaying of treatment non-invasively the patients or delaying intubation in the critical care areas. And what's new about the power of predicting, the ability to predict the failure of non-invasive device so that we can, at the proper time, decide to upgrade the treatment, eventually to intubate the patient. Just starting from the first point, we know that NIV as a non-invasive respiratory support has been used widely in the spectrum of respiratory failure, and even in the spectrum of hypoxemic respiratory failure. However, as you know from this slide, the rate of failure may dramatically increase according to the severity and the kind of the disease underlying and determining the failure. And in particular, ARDS, severe and extensive CAP, and other conditions may absolutely determine a great risk of failure for the patients, which can also translate in a risk of death. What we learned from the literature has been in terms of how to treat non-invasively the hypoxemic respiratory failure comes from the cohort of LungSafe, where around 3,000 patients were analyzed and treated by 15% of them by NIV. And when the authors compared the outcome of those patients treated with NIV as compared to those who were intubated. You can see here that the risk of reducing survival is higher in those admitted directly to non-invasive mechanical ventilation, in particular in the subgroup of those patients with less oxygenation at baseline, whereas there is quite a similar actual possibility to survive compared to invasive mechanical ventilation in those patients who are less severe. So this makes the opportunity to discuss around the role of non-invasive ventilation in this particular syndrome, and this I report here this data, this sentence, because it comes from a very recent review of one of the authors dealing with and reviewing data on non-invasive mechanical ventilation in general, in which he also, the author, had the opportunity to conclude that may be a physiological benefit to NIV in mild condition of hypoxemic disease, but the clinical impact remains uncertain. And this is therefore why the guideline from European and North American countries came to the conclusion that NIV have a potential use to treat de novo acute respiratory hypoxemic failure, including this treatment as a preventive strategy to avoid intubation. However, there are, due to the level of uncertainty in the literature, in the data, there is no room to offer a recommendation in favor of using as a first-line treatment non-invasive ventilation to treat this kind of very dangerous and harmful syndrome. However, even an intensivist may offer the opportunity for non-invasive respiratory support to be used in the early phase of developing hypoxemic syndrome. Indeed, may help non-invasive support like NIV, but not only NIV, to avoid mechanical intubation and mechanical ventilation. However, it may be harmful because if you delay the use of and the decision to take endotracheal intubation, you might promote the risk of patient self-inflicted lung injury. And this is due to the fact that avoiding intubation when this is the proper time, of course, the patients may produce a self-induced damage. And however, high flow nasal cannula and even NIV, especially by the helmet interface, still remain promising tools that may be used early in the phase, in the clinical phase that we have to treat with these patients. So still remain the problem on how we have to intubate the patient. And if you look at this chart, plotting the risk of death to the disease severity at the time we decide to intubate or not to intubate the patient, you see this kind of relation in which you can see that the risk may increase when the disease severity is too early, so the patient is not so bad to be intubated, because in this case the risk is incremented by the risk correlated to the intubation and the mechanical ventilation, for instance, the infection and the consequence related to the intubation, volotrauma, barotrauma, and so on, or even increases here when you delay the intubation because you are not so prompt in deciding which is the perfect moment to intubate the patient. And so what we have to do is to find a perfect time frame at which the risk is minimized, because it is the perfect time for the patients to be intubated. So we have not to waste time, but not to hurry the time in order to intubate too early the patients. And this is because we have to monitor the patients and prevent what hypoxemic syndrome, like ARDS, may lead to in patients who are treated by oxygen alone or non-invasive respiratory devices. In fact, one of the risks is that if you look at the effort of the patients, the effort means the respiratory effort that the patient requires to maintain ventilation and gas exchange, you can see here, that having such a syndrome may lead to inflammation, lung edema, and lead the patient through a vicious circle in which the increase in the effective effort may in turn increase the lung injury by which the syndrome has begun. So it is important to monitor, or in some way find a way to monitor the patients in order to decide whether or not a non-invasive approach may be good or may be at risk of failure, and so to find out the perfect time or the ideal time at which the patient should be upgraded to different treatments, such as the mechanical ventilation. How we can decide to intubate or not intubate the patients? We have to look at what we call, once, for instance, oxygen or non-invasive devices to treat hypoxemic failure is initiated, a lot of clinical score or indices that has been proposed in order to identify a priori or in the very early phases of the treatment which is the patient or the condition that might be at risk for failure. But however, there are a lot of these indices, such as in this table, indices which are clinical indices like the ROX, the VOX, the ACOR, the Apache. I don't have time to go too much deep into details. There are inflammatory or serum biomarkers. There are indices explaining or measuring directly the mechanics of the lung, and in particular the respiratory effort. And also there is indirect evaluation of the effort through the echography of the diaphragm. However, as you can see here on the right side of the slide, there is a very high level of uncertainty about the power of that each of these kind of indices may provide in order to give us the opportunity to decide whether or not the patient is at risk of failure. And in some cases, even the threshold limits that has been described in the literature are not so perfect, are not so easy to apply to all the patients in the wide spectrum of the hypoxemic respiratory failure. And this has been shown very nicely in a recent experience over more than 4,000 patients admitted to the ICU, initially treated with oxygen, high flow oxygen, and IV, with, of course, a quite huge level of oxygenation needed. And what the authors made in this study was to measure 17 different indices with the threshold known from the literature, and they applied the probability that altogether these 17 indices may provide a very likely indication on to meet the physiological criteria in order to provide a decision whether or not the non-invasive treatment was appropriate to treat the patients, or should we upgrade the treatment. And you can see from the results, taken all together, within the 3 hours of observation and assessment of indices, the maximum level of probability they reached was 20%. So it means that only 1 over 5 patients met criteria physiologically that could allow us to take a decision and a decision in order to intubate or not to intubate the patients. Indeed, we talking about the effort of the respiratory effort, we studied in our center the problem by measuring the esophageal pressure with an esophageal balloon and looking at which is the deflection and the effort of the patients, which is here described by this graph. You see here a patient with a deflection of around 30 centimeters of water, which means a high pressure, a high level of effort, developing breath by breath, which may lead to the process that I described before, so the self-induced lung injury in this condition. And here on the left, a different pattern of breathing with a very more limited breath, which can be reached even when, for instance, non-invasive respiratory support is applied to the patients, likewise NIV. What we want to study was whether this inspiratory effort may change at 2 hours after a trial of NIV that we proposed to the patients, in order to which kind of outcome lead to the patients. And you can see in these other graphs that according to the outcome, if you see the failure patients who are here in the red frame, according to the level of variation of esophageal pressure or variation of transpleural pressure, in this group of patients, almost all remain unstable or increased the level of the pressure, whereas those who succeeded with non-invasive ventilation reduced the effort. So it means that you have a very short time in which we have to decide whether or not to apply or upgrade the therapies to these patients. However, this refers to an invasive method to measure the respiratory effort. So we studied, go on. So we studied an alternative method which seems to be non-invasive and much more easier to take for the patients, which is the assessment, the early assessment of the inspiratory effort by measuring pressure at the nose. Inserting a pressure transducer in the nose, in the nostril, which reflects the pressure not only in the nasal cavity, but also at the opening of the airways, and leading the patients to breathe spontaneously, not to make a high inspiratory effort, because this, of course, limit the possibility to have this kind of tracing. If you leave the patients to breathe spontaneously with the mouth closed, you can observe the level of effort that he or she applies breath by breath, and you can measure this. Our problem was to be sure that these kind of measurements that can be applied for monitoring very early, even in the condition of a acute respiratory failure, really reflects the level of pressure that we are sure to measure in the esophageal, with the esophageal balloon. So we applied, first of all, the measurements on tidal breathing, under spontaneous breathing in volunteers and in patients, and again under NIV, showing that NIV may help to reduce the effort of the patients, so may provide an help and successful treatment for the patients to be treated during an acute phase. Following this, we also compare, as you can see in this photo, simultaneously the pressure to the nose and the balloon inserted in the esophagus. We compare the level of concordance of the two measurements, and we found pretty well that this level of concordance is almost linear, so it means that what we measure in the nose, in the nostrils, in that way, is similar to that we can measure in the esophageal reflecting, so exactly the effort that the patient takes breath by breath. And the ratio, this is under spontaneous breathing and even here under non-invasive mechanical ventilation. So the pressure delivered to the mechanical non-invasive ventilatory device does not influence the measurement at the nose. And the ratio between the two measurements is almost 2 to 1. So it means that for every centimeter of water of effort, of pressure applied and measured at the nose, this refers to 2 centimeters more or less of water in the esophageal. And this kind of ratio is fixed, independent on the fact that you use spontaneous breathing, you measure under mechanical non-invasive ventilation, and so on. Then, following this observation, we want to be sure that this kind of measurement was accurate enough in order to predict the failure of success of any non-invasive respiratory treatment, in particular non-invasive mechanical ventilation. And so we made an analysis, this is the graph of the analysis, showing the ROC curve and the level of accuracy, which was very high, 0.98, at the threshold value of 5.1 centimeter of water of the nasal pressure. So it means that above or below the level of 5.1, you can find more likely the patients who are at higher level, so are likely to fail the treatment, or less than 5, and so it means the patients who are less likely to fail the non-invasive treatment. We wanted, again, to confirm this data in the clinical ground, and so we have the opportunity to treat prospectively 60 patients treated by nasal cannula, high-flow nasal cannula during acute hypoxemic respiratory failure due to different causes, mainly pneumonia, and divided according to the outcome, which is the upgrade or not of the therapy. We divided these samples into 2 groups, the low pressure group versus the high pressure group. And you can see from the graph, the low pressure group, so those below, at the beginning of the story of below the level of 5 centimeters of water, are less likely to upgrade the therapy. So it means NIV or fail the therapy, NIV or even intubation. Those patients who baseline are with higher pressure are more likely to be upgraded to treatment up to mechanical ventilation. And so what's new in the field? Because we are not satisfied that simply, and we have also to confirm this data in the clinical ground, that simply one pressure delivered or measured at the external nose may be enough, sufficient enough in order to predict the outcome of the patient or gave us the indication whether to upgrade or not to upgrade the treatment in such a syndrome, which is critical because, as I tell you before, delaying the decision may deteriorate the condition of the patients. I think that something new is generated, or there is a possibility to generate something new opportunities through the artificial intelligence. So we met and discussed with some biostatistics in engineering at the University of Warwick, which is in the Middle East of UK. And retrospectively, we reviewed the data that we obtained in our trial and in trial of other colleagues. And first of all, we have the opportunity with them to create a model of machine learning by feeding this machine learning with data very simply obtained, like here at baseline or after 2 hours from the patient. So measuring age, SOFA score, ROX index, respiratory frequency, heart rate, P/F ratio, and so on. Data were taken from around 200 of patients, and the failure rate on the clinical ground was around 40%. We also had an external control of data using databases which are publicly available in the United States, and this is a procedure required to get good quality of the data in this kind of mathematical models. And what we found is that whenever you include or not blood gases, the area under curve, so the accuracy using this particular machine learning model, and one in particular which is called, I don't remember exactly, but one of these, you see here, demonstrate a better accuracy as compared to the single available data that we applied as a predictive threshold or predictive parameters having a threshold in order to predict the outcome. And so it opens the opportunity that this kind of mathematical models may help at the bedside the clinician in order to take early a decision. And you can see here, if we look at the rank of importance of the parameters included in the mathematical model, you can see here that whenever you don't use or you use blood gases, the level of oxygenation delivered, or the oxygen delivered, or the respiratory frequencies are the most important. So it comes back to the physiology that when the patient increases the effort and increases the dyspnea and of course increases the respiratory frequencies, this is one thing that not only the clinical observation but also a clinical and mathematical model may help giving the physician a very good indication on which kind of patients may fail or will not fail any non-invasive failure. So this model, which is specifically called support vector machine, which is an algorithm including all the parameters, demonstrated a considerably improved predictive accuracy compared to the other currently used clinical practice, which are very common to be used in the ICU, for instance, like the ROX index, the ACOR score, and so on. Another way of applying artificial intelligence could be to generate digital twins of what happens in the real practice to the patient. And again, we use our data sets of patients of a study from a study that we published before, and through this particular application of artificial intelligence, we replicate the characteristic of the patients in terms of PaO2, PaCO2, volume delivered and volume delivered to the systems, or the pressure delivered to the systems, a twin, which is in green, which replicates exactly what happens in the reality to the patients and what we have observed. Based on this kind of replication, we are quite confident that we are able to reproduce the behavior of the patients of the real practice. So we have data in the real practice that we can reproduce. But which is the aim of reproducing digital twins? Is that through mathematical models, and the behavior of the patient in the real practice from very easy data, PO2, PCO2, oxygen saturation, tidal volume delivery, and so on, we can derive some mechanical information of the lungs of that patient. And when we took this model, mathematical model, and we divide according to the outcome that we have in the clinical practice, failure or failure, which is in red, or success of the application of non-invasive ventilation, even in this case was 2 hours of application of non-invasive ventilation, you can see that the information given by this mathematical model is that those patients who failed non-invasive ventilation had higher strain, but especially higher stress to the lung, developed more power to the lung, and also developed more transpulmonary pressure, which refers and is associated with failure of the treatment. So this is another example on how we eventually and in the future we can apply through the app at the bedside some information and obtain some information very easily and very quickly in order to decide what to do. Because, of course, having an early information that the red patients are going worse, of course, may help us to decide early on what to do to the patients. And forecast via digital version of patients the assistance to physician they are assisting the patients in a non-invasive environment. So to conclude, and I think that I am in time, severe hypoxemic acute respiratory failure is recognized a very harmful condition for the patients and requires, of course, competence by healthcare professionals, even in the area of pulmonologists. Notwithstanding, non-invasive respiratory support may have a role, a significant in the early phase for treating this kind of patients, in particular when the syndrome is at the very early onset. Strict physiological monitoring is very important in order to decide what to do when we manage the patients non-invasively and in order to avoid delay in upgrading the therapies required by the patients. And finally, artificial intelligence development maybe is the new forefront for outcome prediction when using this kind of non-invasive device, which can be hopefully useful in the next years in the clinical practice. And this is my last slide to thank my research group on the field, all the group in Modena, research group in the critical care stream, research stream, and the associated collaborators, School of Engineering in Warwick at the University of Ferrara, and clinical center in Italy and even in Amsterdam, and other laboratories that may help us in producing this kind of data. Thank you very much for your attention.
Thank you, Professor Clini, for this very interesting talk. We have time for a couple of questions from the floor. Is there any question or a comment?
No, it's different because we have to use. We get the patency of that device actually, but we are in the phase that industrial will come. So we are not actually in the condition to use it widespread. We used and we made it by manufacturing in our center. Because one of the problems is that you close absolutely in a very good way the nostril, because so we have to use a specific material that is able to be deformed and adapting to the nostril of the patient. We are on the way to take some agreement with companies that may be interested in producing on an industrial basis the device, and so we hope that in a couple of years we will be able to have a product on the market in order to measure this one. But of course we need some more research data. We are in contact with other centers, like I indicated here, in order to have much more data on the patients and the spectrum of the disease, in order to have a lot of measurements that can help to understand whether or not our suggestion and our publication may be applied worldwide or in every condition that we have. But I think that due to the nature of this kind of small device, which is a pressure transducer, we can be able to obtain easily from the patients who is not in a very good condition the possibility to get this kind of measurement, the pressure, so indicating the effort of the patients, because I have to also to remember that even in the ICUs, the use of esophageal balloon is not so common, and less than 1% of the patients admitted to the ICU with some similar problems have been instrumented with esophageal balloon. So having a non-invasive device, very easily to apply and realistic for having a realistic measurement in the nostril, in the nose, reflecting what's happening in the respiratory system, I think it could be very useful to have, and maybe it could be a new forefront for monitoring the patients even outside the ICU or the respiratory intensive care unit, for instance, in emergency room, and have some information on how to deal with non-invasive respiratory device, which in some way is very critical. When you are in emergency room, one of the most common things is to have or observe that patients are left for hours without any monitoring, treated by oxygen, but no one take care of what's happening in terms of effort, change of the respiratory characteristic of the patients. And of course, when they transfer the patients to another department or unit like pulmonology, maybe that the patient has already developed something that goes wrong. So it's difficult then to take a decision at that, other than intubation.
Okay. Professor Banaikis.
Of patients that are outside of the ICU, since diaphragmatic ultrasound is a tool that we can have also in the ward, why do you think it's uncertain, and what you expect more to be more able to use diaphragmatic ultrasound monitoring effort and predicting failure or success?
There is a parameter that we can quite easily obtain from this kind of method, which is the thickening fraction. And the thickening fraction is a surrogate marker of what's happening in terms of effort. The problem with this is that, of course, you have to be absolutely able to perform and to read the data, and which is not common for everyone. And this is one of the reasons why we feel that having a simple pressure under tidal respiration in the nose might be much more easily. And this is also one of the factors whether in the literature the thickening fraction of the diaphragm, yes, is an opportunity, but it's not easy to take.
Okay. Thank you very much.
Thank you.